Good evening, everyone. I'm Dr. Mike Mills. We're coming to you live from Kittanning, Pennsylvania, which is in Armstrong County, about 45 minutes north of Pittsburgh. And tonight's class is called Sciatica, Get to the Cause. So a little bit about myself. I have been practicing chiropractic at Mills Chiropractic Center in Kittanning since 2001. And this is a topic where we have had the opportunity to help literally hundreds of patients. And sciatica can be an extremely debilitating condition. From the fire down your leg to trying to ride in your car to get to work to being able to bend down and pick up your child or do laundry or walk up steps. That sciatica can truly be something that is debilitating for people. So we're excited to get into the information and provide you with some direction and some solution and some answers on how you can get relief and recovery and feel better. So what are we going to learn tonight? What is sciatica? I think it's important that we define what this condition is. For a lot of people, there's some confusion about where does it come from? What does this word really mean? What are the causes? What are the symptoms? What are the treatment options? What to do next? And how to help prevent your sciatica from returning. So let's start with what is sciatica. So if you look at the picture here on the right, you're going to see that it's labeled sciatic nerve. So the sciatic nerve is what sciatica is named after. So there is a nerve, and if you look on the picture, you can see it shows L4 down to S3. So the nerve roots, or the little nerves where they come out of the spinal cord, come out of your spine from L4 to L3. They form a bundle of nerve that goes down your leg. We call that the sciatic nerve. So sciatica comes from the name sciatic nerve. It is not something you catch. It is something you develop. And really, when we say sciatica, what we're referencing are symptoms. Really, what's causing the condition is the problem. But sciatica are symptoms from irritation or compression of the sciatic nerve. A misconception is that sciatica is a disorder. However, sciatica is really a symptom of a disorder. Different names that people would give sciatica is radiating pain, meaning the pain shoots or moves down through the nerve. So it is originating from the low back, which we can see from the picture, but it's shooting down the nerve into the leg, and we call that radiating pain. Sometimes you might even hear it referred to as referred pain, and the reason they'll say referred is because while the problem in most cases is coming from the low back, when you're feeling the pain in your calf, the pain is referred to there. Neuralgia, which just means pain in a nerve or nerve pain, or neuritis, which is inflammation in a nerve. So all of those words you could hear associated with sciatica. Sciatica in the classic sense goes down the back of the leg the whole way to the foot. So just because someone has pain in their leg or nerve pain in their leg does not necessarily mean that that pain is coming from the sciatic nerve. While it could be, it's very common for patients anytime there's pain in their leg to feel like they have sciatica. What are the symptoms of sciatica? It could be a dull pain, it could be an achy pain, it could be sharp. Some people will say it feels like a toothache, even some paresthesia or pins and needles or electric shock. Other symptoms include burning, which is not uncommon for nerve pain to present as burning. We'll even have patients say they feel like they have a hot poker jabbing them in the gluteal or the butt cheek. You could, over time, develop some numbness or tingling sensation. Numbness is typically classically from compression of the nerve. So all of these symptoms would be possible. If you look at the picture we have here on the screen, you're going to see the the red leg is showing you all the areas where you could be feeling pain the whole way down through the leg. Interestingly enough, the pain does not always, even though it originates from the back, there's times that the pain will just show up in the calf or just show up in the foot. It doesn't always have to be the whole way along that distribution of the nerve. So what are the causes of sciatica? Again, sciatica is not a medical diagnosis in and of itself. It's a symptom of an underlying medical condition. So sometimes the way we'll say it is the pain of sciatica, well, we don't want anybody to have that and most people don't enjoy it. The pain is not the problem. The problem is what's causing the pain. And so what we want to do is get to the cause of the problem. So if you look at the pictures that we have here, the causes can be a lumbar bulged or herniated disc, a vertebral subluxation or a misalignment, a joint dysfunction of the lower lumbar spine, pelvis, or sacral area in your hips. It could be from degenerative disc disease. It could be from a condition known as a spondylolisthesis or from spinal stenosis. And we're going to get into that. Could also be caused from a muscle spasm squeezing the nerve. So if you look at the pictures that we have here, we show the bulging disc. We show an inflamed or irritated joint, typically from what we call vertebral subluxation. And we show that the muscle can be in spasm squeezing on that nerve as it comes through that area. So what we're going to do is we're going to go through each one of the causes of sciatica so that you can understand how that affects the nerve. And then we'll go into some solutions and what you can do about it. So lumbar disc herniation. If you look at this picture, you can see the circle is where the disc is at between the two bones and how that is affecting the nerve where it comes out of the spine. Now, let's look at some pictures here so we can more clearly understand what a lumbar disc herniation or bulge is. If you look at the bottom picture with the green circular jelly-filled center in the disc and the pink around the outside. So what we're looking at here is a picture of the spine from above. So if you look at the bony structure with the point coming off the top, that would be going toward the back. If we're looking at the pink circular structure with the green in the middle, to the bottom of the screen, that's going to be to the front or toward the belly. So what can happen is that pink outer layer we call the annulus fibrosus, or the annulus, we refer to them as annular fibers that wrap around the nucleus pulposus, which is the green jelly-filled center. So when a disc starts to bulge or to herniate, what happens is if you look at the top picture, it shows you that the green jelly-filled center starts to migrate or move out toward the nerve. So if you see in the bottom picture the spinal cord, and you can see in the top picture how the spinal cord is being squished to the side, and that's affecting the nerve root. So what happens is those annular fibers become disrupted or start to tear or weaken, and that allows the nucleus to start to shift or move back, and we call that a herniated disc or a bulging disc. There's varying degrees of that. Tonight's seminar is not to get into every detail of that. However, you can see how that could affect the nerve. And so here we have the bulging disc affecting the nerve in the back, and that's what's affecting the pain going down the leg. Some interesting facts that we've listed here are up to 93% of disc herniations decrease in size over 12 months or longer. So sometimes people will say, well, if this disc is bulging, the only solution to that is to go in there and cut that off and to trim that. And that's not necessarily the case. We know that 93% of the time that disc will decrease in size over 12 months or longer. Now, 10% will increase in size in the first 6 months. So that disc material can slowly kind of migrate, or that jelly-filled center pushes out to the side slowly as the fibers tear and allow that to happen. So that is one way that can be affected. Interestingly enough, a decrease in size is not always related to a change in symptoms. So there's a lot of stats that we have to know about bulging or herniated discs, but if we look at asymptomatic people, people that are not having back pain or sciatica, and we look at people, let's say ranges from anywhere from 30 to 80 years of age, we know that in that age group, depending on the literature we look at, that somewhere between 60 to 80% of those people are going to have a bulge or a herniated disc in their spine, even though they don't have pain. So the presence of a bulge or a herniated disc does not mean that you are going to have pain. You could have a bulging or a herniated disc and have no symptoms whatsoever. The severity of the herniation is not always directly related to the amount of pain as well. So the literature also tells us that only about 2 to 4% of patients will have surgical indications from a herniated or a bulging disc. So the point here is to say, just because you have a bulging or herniated disc, in most cases, in 95% of the cases or greater, surgical interventions are not necessary or would be indicated. Another cause of sciatica would be degenerative disc disease. So what is degenerative disc disease? It's not a disease that you catch. It's a disease where the disc starts to thin. So if we look at the disc between the vertebrae, they start to thin or squish down. So if we look at the picture that we have on the screen, you're going to see the healthy disc, and you're going to see how nice and thick that healthy disc is. When we go down one, we're going to see the degenerative disc. You see the arrow pointing to there. You can see that that degenerative disc is thinner than the healthy disc. So those discs between the bones are cushions and spacers. And when that space is thinned, it's going to decrease the size of the opening where the nerve can come out and go down the leg. And so the nerve can be irritated there again. So disc abnormalities are commonly asymptomatic, meaning a lot of people with degenerative disc disease have no pain or symptoms whatsoever. I put some statistics on the screen here for you to be able to look at. At age 20, 37% of the population has degenerative disc disease. At age 50, 80% has degenerative disc disease. At age 80, 96% has degenerative disc disease. That does not mean that they have sciatica. That does not mean that they have back pain. It just means that they have thinning of the disc and typically osteoarthritic changes associated with it. So if you look at the area on the picture or the diagram that shows the disc is thinned, you can see that the edges of that bone are also roughened along there. And those spurs that are building up on the bones can also come back. You can see the red area of the impinged nerve that can be affected. So a herniated disc could contribute to sciatica. Degenerative disc disease can contribute to sciatica. Lumbar stenosis can also contribute to sciatica. So what is lumbar stenosis? Stenosis simply means narrowing. So we can have narrowing of any opening, or we can have narrowing of an artery. In this case, we're talking about the spinal canal. So we have a couple pictures on the screen here. If we look at the picture to the left, or the one beside the person standing there, that is a healthy picture looking again at the spine from the top. So the front of the person would be toward the bottom of the screen. The back of the person would be toward the top of the screen. We're looking straight down on the spine. As you can see, there's nerve roots coming out of each side between what we call the facet joints or the zygapophyseal joints and the disc. And you can see the opening for the spinal canal. So that is a healthy, normal lumbar, vertebrae, and spinal canal complex. If you go to the picture to the right, you're going to see that the area around the spinal canal is squished in. They have it labeled as red. What happens here is there's a few things that happen. You can see that if the disc would bulge or push back, that would close the spinal canal. If we got arthritis around those joints, that would also occupy space and close off around where the nerve roots come out in the spinal canal. And there's also a ligament. So that process that's sticking straight up, if you follow it down, it almost looks like a wishbone or an upside down Y along that bone. From there, there's something called the ligamentous flavum, and that is a ligament that attaches the two vertebrae, and it can thicken and also close the canal. So if that spinal canal becomes narrowed, so if we take a picture, if the spinal canal is supposed to be big like this, and I narrow it down, it gives less room for the spinal cord and the nerve roots to come out. That can cause irritation to those nerve roots from L4 down to S3, which we showed in the picture at the beginning. And that can also cause sciatic nerve irritation or sciatica. Interestingly enough, there's no correlation between MRI findings of stenosis and the presence or absence of low back symptoms. So just because there's stenosis doesn't mean you have low back pain. The presence of stenosis on MRI does not predict future low back pain or radiculopathy. So if we have someone that has stenosis on an MRI, that does not predict that they're going to have back pain or sciatica. They could, but they may not. And there's little correlation between MRI severity and clinical severity. So just because on MRI the severity of the stenosis seems to be great, that doesn't always correlate with the amount of symptoms. Sometimes the degree of stenosis can be minimal and the symptoms can be very significant, and vice versa. So lumbar stenosis or narrowing of the spinal canal is also a possible cause of sciatica. Spondylolisthesis is where you can see that the vertebrae here has slipped forward. You can also see that in this case, there's a fracture of what we call the pars interarticularis, or the spinal vertebrae in the back, and that's allowing that to slip forward. Again, if we go to the next slide and look at this, there's differing degrees of spondylolisthesis, and there's differing types of spondylolisthesis. If we look at the picture on the top, in that case, we're talking about degenerative spondylolisthesis. So that's where, because of arthritis in the spine, osteoarthritis typically, and degenerative disc disease, it will allow the vertebrae to start to slip forward. When that happens, it narrows the opening for the nerve to come out and will cause irritation to that nerve, could cause sciatica. So 3 things we look at in degenerative spondylolisthesis, which just means the vertebrae has slipped forward. Don't get caught up in the big word. But females are 6 times more common than males to get a degenerative spondylolisthesis. The 4th lumbar is the most common place, so the next to the last vertebrae of the spine in the low back, and over 50, almost always occurring in patients greater than 50 years of age for a degenerative spondylolisthesis. There's also a traumatic or an isthmic spondylolisthesis. Those typically happen from trauma, which in that case, those patients would typically be ending up in an ER. But sometimes you can have stress fractures in children. Typically, maybe like a gymnast, someone who's hyperextending a lot, and it can cause a stress fracture and allow that vertebrae to slip forward and contribute to that. So that's something we have to look at and pay attention to. But the slipping forward of that vertebrae is another cause of sciatica. The next one is Piriformis Syndrome. So now we're moving away from a bone or a disc causing the pain or irritation to actually a muscle affecting it. So if you look at the 3 diagrams that I have listed here, you can see the red muscle. That muscle, we're looking at the person from behind. So that bone in the center that you're seeing is called the sacrum. And the little bumps on the bottom are what we call ischiotuberosities. That's what you sit on when you sit. But you can see how the nerve comes right past that muscle. In a percentage of the cases, it can actually come through the muscle. So 80% of the time, the nerve passes anterior, like in the first picture, the picture to the left. It passes anterior to the muscle, exiting below the piriformis muscle. So piriformis is the name of the muscle that's So don't be confused by what is that or what does that mean. So what we're saying is that muscle can tighten or shorten, and when it shortens and tightens, it enlarges, and that occupies space and closes down the space for that nerve to come out and can cause irritation to the sciatic nerve. 14% of the time, one branch passes through the piriformis and another branch passes in front of or anterior to it. Other variations include undivided nerves that pass through the muscle, and the division passes both anterior and posterior to the piriformis. So this is another possible cause of sciatica, that muscle can shorten and tighten and compress or irritate the nerve. If the nerve is coming through the muscle shortens and tightens, it can squeeze the nerve there. Vertebral subluxation complex is another condition that can cause sciatica. So in chiropractic, we call it vertebral subluxation. It could also be considered a joint dysfunction. So in this case, we don't have a dislocation of the joint. What we have is the joint is typically either stuck or misaligned, or it's just not moving or working properly. And when that happens, it creates irritation to the tissues, inflammation, swelling. So in other words, when the joints are stuck, what happens is that causes inflammation in the joints, irritation to the nerves, and tension and tightness in the muscles. When that is happening, there's a chemical reaction that happens from the inflammation in the area that irritates the nerve. This is probably one of the most prevalent or common causes of sciatica. So, do you have sciatica? The question really comes down to a proper diagnosis. So we need to know, where is the nerve being irritated? Is the nerve being irritated because of a herniated disc? Is it being irritated because of degenerative disc disease or narrowing? Is it being irritated because of a slipped vertebrae or a spondylolisthesis? Is it happening because the piriformis muscle is tight and shortening? Or is it from a subluxation or a joint dysfunction in that area that's creating inflammation and irritation, a chemical irritant to that nerve that is leading to the pain? So a proper diagnosis is the most critical part of this whole process. Knowing that you have sciatica is important, but knowing what is causing the pain is more important, because that's going to determine which treatment option is going to be the most effective treatment option for you in your case. So the first step is determining what is causing the sciatica. And how do you determine that? You need to do a case history, a physical exam, and a orthopedic neurologic exam in order to determine what is the tissue that is irritating the nerve and causing the problem. So what diagnostic testing is typically appropriate? Well, that depends on the physical exam. It depends on your presentation and the amount of pain, the history of trauma or possibly not trauma. But typically an X-ray is the simplest and easiest imaging possible to look at. Is there degenerative disc disease? Is there osteoarthritis? What is the alignment of the spine? Is there maybe some curvature or scoliosis in the spine? If more imaging is necessary, then we would look at MRIs, possibly a CAT scan, maybe a nerve conduction velocity test to see exactly where the nerve is being affected. But each individual case is going to determine which diagnostics are most appropriate. So what are your treatment options? What do you do about it? Okay. Really, we look at two options. We have two categories of options. We have conservative options and we have surgical options. So what are your conservative options? Chiropractic care, standard medical care, physical therapy, injections. Surgical options are a discectomy or a microdiscectomy, a laminectomy or a laminotomy. We're not going to go into the surgical options at this point. Rarely are surgical options considered to be the first option. Most of the time, 6 weeks of conservative care is necessary in order to even order an MRI in a lot of cases, because we know that most cases are going to respond favorably to conservative care. And that's what most patients want. I mean, most people are not looking to rush into a surgery. So what are your options? We could just look at Tylenol or acetaminophen. It's one of the most commonly recommended medications for people with back pain. But recently, the Lancet released a study which showed that the results were really no better than a placebo for back pain. In January 2014, recommendations were made to not prescribe more than 325 milligrams per day because the benefits do not outweigh the risk. And these findings make the prescription or the recommendations of Tylenol or acetaminophen challenging, because especially those patients who are unable to take the medication to begin with, such as patients with current cardiovascular conditions. So it's contraindicated in most cases to take acetaminophen if you have a cardiovascular condition. So really not a great viable option here. NSAIDs, what are NSAIDs? They're non-steroidal anti-inflammatory drugs. Most people are familiar with them. Similar to Tylenol, there are many patients with cardiovascular conditions who are unable to take NSAID. So if you have a cardiovascular condition, which in America is a lot of people, NSAIDs are contraindicated. I put an article up here from Spine Journal where they looked at spinal high velocity, low amplitude manipulation, essentially a chiropractic adjustment for acute non-specific low back pain. This is the first time that spinal manipulation or chiropractic adjustments was investigated in a double-blind randomized controlled design, showing clear superiority compared to the placebo or NSAID. So in this case, it shows that chiropractic treatments were superior to non-steroidal anti-inflammatories. What about epidural steroid injections? I used the Journal of Bone and Joint Surgery here, and it says that, you know, epidural steroid injections are common choice for most neurologists and interventional spine specialists. While certainly more direct than oral medications, the long-term implications of getting a series of injections are still being researched. And this is primarily, as we're talking about low back pain, for patients without radicular complaints that have not exhausted other conservative measures. They may not be the best choice. So if you don't have radicular pain, which in this case we're talking about sciatica where there would be radicular pain, we really don't have a lot of great evidence for epidural steroid injections. Interestingly enough, I think most people aren't familiar with this fact that there's a 21% increased risk of vertebral fracture with every epidural steroid injection. So this is not what we would consider to be the best first line of defense option for most people, more of a last resort. What about physical therapy? Physical therapy can be an important tool for some patients. We believe and we think that the research shows that stretching and strengthening is best done after proper biomechanics have been established. In other words, after the spine begins to function normally and the joints are moving and functioning, the irritation is coming off of the nerve, then we want to step in with the stretching and the strengthening. This is why patients are encouraged to engage in active exercises after their active chiropractic care has been completed. Chiropractic care does not require pre-authorization typically, and it does not require a referral. So we are considered a portal of entry care provider. So we know that the sooner the patient begins care, the better the outcome. So there's less delay. We can get people in within 24 hours of contacting our office. So we think the evidence shows clearly that chiropractic is the best conservative option and the first level of treatment for sciatica. Chiropractic care is concerned with the function of the neuromusculoskeletal system. When people think of chiropractic, what we call the high velocity traditional chiropractic adjustment, that is only a portion of what we offer at our office. For patients in acute pain, or meaning new severe pain, or patients with osteoporosis, we offer low velocity techniques, instrument adjusting techniques, table assisted techniques, as well as a variety of modalities to help us in this initial phase of care. So I think that's important for people to realize that maybe they had one experience with chiropractic and they assume that that's where it is everywhere, and that's not necessarily the case. So we're going to get a little bit nerdy here with some research as we wrap this up, but I think it's important to realize that the science supports with what we're saying. So this first research article that I'm going to show you here talks about symptomatic patients that we did an MRI to look at and see that there was a confirmed lumbar disc herniation. So we have had situations where patients feel that if they have a symptomatic herniated disc, that chiropractic care is contraindicated, which that is not the case. We've had primary care physicians that have had patients discontinue care because they had a symptomatic disc herniation and they didn't realize that chiropractic was a viable option. But the research shows that it clearly is a viable option, that it is safe, and that's where our level of expertise is determine which techniques are appropriate for that person. But when they looked at the chiropractic adjustments compared to nerve root injections, after 1 month, the numerical rating system scores of the patient rating the pain, there was a 60% improvement after 1 month in the chiropractic case, only a 53% improvement in the nerve injection group. And remember, there's a 21% increased risk of fracture every time we do an epidural steroid injection. So we see that chiropractic is clearly a superior option. When we combine chiropractic with therapy, so this article is titled A Non-Surgical Approach to the Management of Patients with Lumbar Radiculopathy. So that's pain radiating out of a nerve from the lumbar spine, secondary to a herniated disc again. So this is another case of herniated disc. So we're looking at chiropractic and therapy. Listen to what, and I put these in quotes, listen to what we get from this article. Nearly 90% of the patients reported their outcomes to be either excellent or good. Clinical meaningful improvements in disability was seen in more than 70% of patients, and clinically meaningful improvements in pain intensity was seen in 74% of patients. These improvements were maintained for 14 and a half months after care was finished or treatment was finished. So these were lasting results. Improvement in self-described reporting measures as good or excellent in 80% of the patients, and clinical meaningful improvements in pain and disability seen in 79 and 73% of the patients respectively. So here we're looking at if the sciatica or the radicular pain is caused from the disc herniation, the chiropractic is a very viable option. Here we're going to look at one of the techniques we offer in our office. This is actually a picture of, we have 3 of these tables that we use. They're called flexion distraction tables, where the table actually flexes and distracts the spine. But we can see here, this is from the European Spine Journal. I put the reference there. It says a greater decrease in visual analog scale. So in the patient rating their pain among patients with radiculopathy. So that's pain radiating right down the leg, which what we're talking about with sciatica should be expected with flexion distraction. So this is a very safe, gentle, easy technique where we can create a negative disc pressure. So we can create negative pressure in the disc to try to help to pull that herniation away from the nerve and help that patient get better. This is a great study here. This was done in Spine Journal, and they compared usual care, which was physical therapy, narcotics, NSAIDs, and reassurance, and with what they called evidence-based care. Interestingly enough, in Spine Journal, they referenced chiropractic, exercise, NSAIDs, and reassurance as the evidence-based group. Here was their results. The evidence-based group demonstrated significantly greater improvements in reported function through 6 months follow-ups. So when we compare usual care to an evidence-based approach, which is chiropractic, exercise, NSAIDs, and reassurance, the chiropractic evidence-based approach was a superior option. So what is your next step? What do you do? At our office, Dr. Brown and myself are both trained and have a lot of experience in treating patients with sciatica. We believe that we should be your first choice in conservative manage of sciatic care. Interestingly enough, Dr. Brown just recently completed at the University of Pittsburgh the first ever primary spine practitioner certification program. So this is the first program that has been offered like this through the University of Pittsburgh Medical Center at the University of Pittsburgh, where he is certified as a primary spine care practitioner, meaning as the first line of defense to be able to examine and evaluate what direction is best for a patient with low back pain, spine pain in general. So you can look this program up. This is very exciting. It took 18 months for Dr. Brown to complete his coursework, and we're very proud of him as being part of our practice and to have that resource here available to us. Myself, I am a certified wellness practitioner through Life West University, which is through the International Chiropractic Association. What that means is my training is in nutrition, exercise, and lifestyle modification. So essentially how we can use a wellness lifestyle. Let's face it, things like obesity play a role in sciatica and back pain. And so I am certified with the as an obesity prevention and education expert in order to be able to help people through that process as well. And we have lifestyle programs along with the chiropractic care to help manage the inflammation associated with these types of conditions as well. So our office offers you 2 doctors that consult on every case to make sure you are receiving the best care possible. We are open 6 days a week. So as far as availability is concerned, if you call us during office hours, we will see you that day. It's one of our policies. Our team is nothing short of amazing. We take great pride in our customer service. We take great pride in how we treat people and the kind of care that you can expect to get as far as friendliness is concerned, care, being accommodating and sincere. We believe that we are the best at doing that. Please don't take that as being arrogant. It's just something that we take a lot of pride in and we take very seriously, that how we treat people and the service that they get is extremely important. We have developed what we call a health without hassle guarantee. You can see the little emblem. I put that on the screen. If you go to our website, you can click on that and read that. Really what that says is that we are always going to put your best interest first. We're not going to recommend things that you don't need. And that's what we would expect for ourselves, and that's what we would expect as a provider. We're network providers for every major insurance. I really don't know of a company that we're not providing for, but our goal is to take the headache out of insurance. We know that that can be difficult, and we have a financial tech here that is an expert at making sure we know what your benefits are and verifying them. We don't think there should be financial surprises, and we make sure you don't have those. So we have something at our office that we call We Believe statements, and I'm going to read them to you. I know you can see them on your screen, but we think that they're extremely important. And that is, we believe your health is your most important asset. We believe that investing in yourself is the best investment you can make. We believe in same-day appointments. We believe in using your insurance should be easy. We believe that results matter. We believe that your time is valuable. We believe in enhancing your care by working with your other healthcare providers. We believe in greeting you with a smile. We believe in affordable healthcare. We believe in being honest. We believe that being honest is the best policy. We believe chiropractic care helps them maximize their potential. We believe in helping with your kids so you can enjoy your adjustment. We believe if we can't help you, it's our responsibility to direct you to someone who can. So we take these very seriously. They're not a cliche for us. They're how we function as a business and as a healthcare organization. So what's your next step? Your next step, we offer a free consultation to all of our patients. In other words, talking to us and seeing if chiropractic or the services we provide are the right option for you. That doesn't cost you anything. So if we can't help, if you're in the wrong place, we will advise you that, and there's no charge involved with that. If you just have questions that you would like to ask, we would be thrilled to sit and discuss them with you. We are in business in order to help you. Your success is our number one priority. So I've listed here our website, our Facebook page. If you're watching this, you're on there. Our YouTube channel. We are constantly filling it with videos to be a resource for you. But if you have sciatica and you're looking for options to get relief, give us a call. We'd love to help you out. If you want to look at how do I prevent sciatica, the best thing you can do to prevent sciatica is to get healthy. Make sure your spine is moving and functioning properly. Make sure your body is fit and conditioned. Make sure you're at your ideal weight and your body isn't inflamed. So there are a lot of things you can do to prevent sciatica. We would love to be able to help you with those as well. So thank you for joining us this evening. It's been a pleasure to share this information with you. We hope it was helpful. This whole class was started from feedback from our social networks of people saying, this is what we'd like to know more about. If you would like another class on any of these topics, anything related to health and wellness, we are going to continue to provide this service as a way to help you be the best version of yourself. So give us feedback, comment in the comment section, message us, let us know what you would like to learn more about, and we will be happy to do that. It's been a pleasure sharing with you this evening. We hope that we can help you into the future. Have a great night.